This is Lance Lichter for AA Today. Can the anesthesiologist affect outcome after CABG surgery? A study from New York. Back in the mid-1980s, there was a study showing that postoperative myocardial infarction after coronary artery bypass graft, or CABG surgery, was more likely in patients who had tachycardia. Most anesthesiologists probably have forgotten the primary finding and remember the study for a specific detail, anesthesiologist number 7. This anesthesiologist, not otherwise identified, had the highest incidence of intraoperative tachycardia, myocardial ischemia, and postoperative myocardial infarction. To this day, anesthesiologists will refer to anesthesiologist number 7 as a derisive term for an error-prone colleague. Anesthesia care has changed significantly since that time. However, the question remains whether a subset of anesthesiologists is particularly skilled relative to a different subset. That's the glass half full question. You can invert that if you prefer, the glass half empty question. The authors used data from the New York State Cardiac Surgery Reporting System for patients undergoing isolated CABG surgery in New York State between 2009 and 2010 to see whether there was a difference in mortality and major complication outcomes across anesthesiologists. The results of their analysis are summarized in the article titled The Impact of Anesthesiologists on Coronary Artery Bypass Graft Surgery Outcomes, which was published in this month's issue of Anesthesia and Analgesia. The study group consisted of 7,920 patients who underwent isolated CABG surgery. 91 anesthesiologists and 97 surgeons in 23 New York State hospitals managed the cases. The authors found that variability across anesthesiologists was highly significant. Patients who received care from low-performance anesthesiologists, defined as anesthesiologists in the 25th percentile in the distribution of anesthesiologists' risk-adjusted outcomes, had an almost twofold higher risk of death or serious complications than patients who received care from high-performing anesthesiologists, even when patients were stratified by their baseline preoperative risk. In addition, the relationship between anesthesiologist and surgeon risk-adjusted performance was poor. What are the distinguishing characteristics of better-performing anesthesiologists? To state that some are better than others is not particularly helpful. We all likely know that, whether we will admit to this in public or otherwise. In addition, if there is actually a volume-outcome relationship with regard to patient outcomes, this paper will have major policy implications. It is about time that we try to look at this issue more closely, especially given how many low-volume providers are present in the New York State database. The authors in the accompanying editorial, Does It Matter Who the Anesthesiologist Is for My Heart Surgery?, note that we should reject the widespread assumption that one anesthesiologist does not change patient outcome compared to another, and accept that instead, which anesthesiologist performs a case matters a great deal. These findings will prompt us to investigate how anesthesiologists differ from one another in practices that affect patient outcomes and to define quality in relation to some unavoidable degree of interprovider variability. They also raise questions about whether anesthesiologist outcomes should be publicized and whether patients should select an anesthesiologist based on that outcome data. Overall, this is a well-written paper and the conclusions are both interesting and provocative. Ever since anesthesiologist 7, we have wondered if there is an anesthesiologist effect on cardiac surgery outcomes. Now we know that anesthesiologist number 7 wasn't an anomaly. This paper may produce a storm of outcry, since because half of us are below average by definition. We are watching the Weather Channel closely. For links and more, go to aatoday.org. That's AA, the number 2, day.org. This is Lance Lichter.